And when we turn it over to you all, I'll let you introduce yourselves, because you all got a lot of titles and a lot of hats and a lot of all that. So I will try to, figure it out.
You just don't want to pronounce my last name, which is okay. You can call me Demir.
Yeah, that's a lot easier.
Let you announce your last name, and then maybe I'll learn it. All right, so we have a little bit of a schedule change. Sam Quinones, it was going to be on November 2nd. However, his paperback book version of The Least of Us comes out November 2nd. And so unless we wanted to chase him around in a book tour radio interview, it was just not going to work. So it shifted by a week. So now we can get more friends to join and all of the things. So just by a week.
All right, so the upcoming ECHO sessions, actually, because of the switching in schedules, next week will be opioids in the older adult. And then the PMP people are coming on the 2nd of November. So lots of good ones coming up. So, and again, then Sam Quinones on the 9th.
All right, so yes, free CME, I'm going to do it so you don't have to. You'll get the little survey thing that'll pop up in the announcements at the end, or in the chat at the end. Otherwise, you'll get the email. Of course, this is being recorded. Y'all know that. If there's more than one person in your room, please chat that in. And I'm sure Demir and Tara would love to see faces. Yeah,
so don't be afraid to turn on. We got a lot of people with their videos on today. Remember, if you need some technical assistance, give us a ring. You can call Aaron. All of our numbers are there, so just call us if there's anything we can help you with a patient.
Yes, or replying to Katie. I think that's kind of been a thing lately too. Just Katie help, and she'll connect you too. So, and the core website, just all the stuff on how you get on ECHOs, information on starting programs. Our contact information is there as well. The manual, now the MDH tells me it should be full approval by Friday, so hopefully we'll have more information on that. But if there is anything you need that would be in the manual or protocols, just email us. I can send that to you.
Yes, remember the Addiction Connection podcast? I think we had another one that was released just yesterday on opioids and suicide. That's the last.
Treatment.
And treatment, the treatment side of that. So that's the last of the opioids and suicide series. So something different next week.
We should do like the last edition of the sugar addiction, because everyone's just dying to hear the end of it.
Maybe.
Okay, so I had to put this in here because it's so gross. So today the background is National Evaluate Your Life Day, thus this contemplative introspective picture. But it's also National Hagfish Day, which is why you all can thank me for this beautiful artwork instead of that icky fish behind us the entire time. And if anyone happens to be named Jared, it is also your day.
Yeah.
And Medical Assistance Day. So we should all thank our wonderful medical assistants that we have in our world. So with that, we will turn it over to Demir. He will teach us how to say his last name, and then Tara from Hazelton Betty Ford. Thinking you're sharing your own slides, correct?
That's not my screen, so I'm not sure who's controlling the presentation.
I was, so I can take mine out. I'll take control.
Okay. Well, you know what? It just means I have an external locus of control if I don't share my own screen. Okay. Well, thank you. You two are so energetic, and I'm just excited to be here with you. And I asked Tara to join me so she can share her expertise, and she'll tell you more about herself. But my name is Demir Ertzen. Feel free to call me Demir. The titles are just force of habit. Actually, last week, I sent our marketing team an email to recognize someone for something they did, and they responded back with saying, we'd like to recognize you for having the longest email signature in the organization. So I need to reevaluate how long my email signature is, and that may include removing some of the titles. But my name is Demir. Like I said, I'm the manager of mental health services at our Center City headquarters, which is our national site. And we're licensed for about 220 residential and day treatment or outpatient beds. Sitting on about 600 acres in Chisago County. I'm also the interim psychiatry administrator for the Midwest region, ensuring delivery of psychiatric services at 5 of our sites in St. Paul, Plymouth, Maple Grove, Chaska, and Center City. And then when I have nothing else to do, I'm an adjunct assistant professor at the graduate school, and I've been here for about 2 years. Tara, would you mind saying a little bit more about yourself?
Hi, everyone. I'm Tara Costigan, and I'm a 5th-year clinical psychology doctoral intern and doing my pre-doc internship here at the Center City location. And my dissertation and all of my clinical training has been substance use focused. So I'm excited to be here.
So to start off, Tara and I talked. We're both very interactive. We don't really plan for presentations. The thing is, if we read off the slides, I might as well just email them to you. You don't need me or her for that. So that being said, you'll have access to these, but we much more appreciate dialogue and engagement. And hey, I see Alex Hubble. Nice that you joined. But yeah, just pop in, say what you think, share your thoughts, and we'll kind of go from there. And so the purpose of the presentation is threefold, and we'll see how far we get along those lines. But identifying how the global pandemic, with emphasis on the United States, exacerbated co-occurring disorders. I think anecdotally, all of us are aware of that, and we can point to clinical examples, but there is increasing research on the topic itself. Examine the role of what integrated care means in treating co-occurring disorders, and then applying some principles and evaluating across levels of care. I just saw another spelling error. Okay, short quiz. And feel free to shout out or type what you think the answer is. The pandemic has led to a 28% increase in major depressive disorder globally. True or false? I'll look at the chat. Seems low, yeah. So we can round up to 3 out of 10. Don't spend too much time. So yes, and I'll give you more examples. The World Health Organization did a relatively comprehensive survey across multiple countries, and they believe that the pandemic has caused about 137 dailies per 100,000 people for major depressive disorder, and 116 for anxiety. And for, as a reminder, that's just the overall disease burden reflecting the number of years lost due to ill health. And we're just coming out of the pandemic to some degree, irrespective of variants that might be emerging. And so these estimates are the best we have at this point in time. They're likely going to continue shifting and changing as people adjust to what is relatively a new normal. In the United States, self-harm blank as a result of the pandemic. Increased, decreased, or stayed the same? And I think this question could be tricky because something that I talked about at a managed care conference is that the pandemic brought about or highlighted societal issues that have always existed. It's not that they are a brand new phenomenon, it's that the stratification of them has never been more prevalent when socioeconomic factors really divide people and push forward some of the issues that have always been present.
Yeah, do you think with that, Demir, that because everyone was doing so much research on the pandemic and how it impacts everything, that we were just identifying, we as in researchers, identifying these things that were always there, we just didn't look before?
Yeah, I think when you look at it broadly, right? Let's say that you are of a disadvantaged background, whatever that may be, if you're identifying as a ethnic minority or of a different sexual identity, that's something that is part of your personality and your life day to day. You learn to adjust to it, whatever that means. And yet when the pandemic came about, it's an added on stressor that exacerbated those existing considerations. But, the thing is, the pandemic impacted everyone. And so it happened to also cut across all these different facets, meaning that of itself is coming from a point of privilege. And I don't know if anyone agrees or disagrees with me on that, but I think that it's always been there. It's just much more of a focus now because it has significant downstream effects. I mean, same with self-harm. The first 0 to 4 months of the pandemic, there has been an increase in self-harm. And since then, no decrease. And Tara, actually, would you mind talking a little bit about what you're seeing even on the residential units? You have more interaction with patients here than I do.
So as of right now, we're seeing an increase in self-harm and suicidality based on coming out of the restrictions and the lockdowns and all of that. People are resuming work, but COVID hasn't gone away. So we're seeing an increase in patients here that are still having complications as a result of COVID. And it's also important to note those that were diagnosed with COVID and have maybe long COVID has also seen an uptick in self-harm and suicidality.
I was just meeting with one of our executives talking about how, before the pandemic, it would be pretty atypical to get a patient who's attempted self-harm twice in the last month, versus now it's pretty common, unfortunately. Right. So when we look at inclusion and exclusion criteria for admission, it's always a consideration because we sit on 600 acres backed by woods and a lake. At the same time, 2 years ago, that would have excluded them from admission. Now it doesn't, because those exclusions would be arbitrary to some degree because of how prevalent it is. Interestingly, though, from the World Health Organization, the US, the rates for self-harm remained the same. In other countries, they decreased as the pandemic moved forward. So think about the societal impact and the sociocultural factors that are unique to this country that may not be the same in others. So suicidal thoughts, if you look at the percentage change, have gone up around 11%, suicide attempts about 4%, and self-harm 10%. Again, also likely underestimates, because we all know that individuals who really want to carry out a plan, they're not going to go out and share that with others. Along those lines, going back to question 2, between January and September, which plays into the self-harm, anxiety and depression have increased between 6 and almost 9-fold. So again, I pulled a random sample of patients from January through August in Center City, their medical records. It's about 1,700 people who discharged, and 75% of them had anxiety and depression. Looking at population demographics or general population health data, that's atypical to have those kinds of levels of anxiety and depression. You'd think that it'd be comorbid with alcohol use disorder, which is again consistent as a CNS depressant. But we're also seeing this, I believe, as a result of the pandemic and people adjusting to what is becoming a new normal. So the pandemic identified and lifted barriers to accessing mental health care. True or false? Some of these are trick questions, so it's not fair. But it demonstrated that implementing virtual mental health care is not only possible, but also cost effective. In the past, organizations that would have taken years to roll out their care have done so successfully in months. The issue is, though, that it expanded accessibility for groups already privileged, right? Typically, young, financially independent young people, another spelling error, with access to private space. Now, what we're also seeing is that private startup mental health companies are falling under the scrutiny of the Securities and Exchange Commission and other law enforcement branches of the federal government for overprescribing stimulants. There is actually, the manufacturer of Adderall announced a shortage, and they believe that it is a result of overprescription in the virtual sector. Substance use broadly and alcohol use increased during the pandemic. Yeah. So it increased on average about 12%. But Tara, you're in the men's unit. I think men use alcohol more so than women. What are you seeing percentages there? And I can add a little bit more broadly.
Well, I can't generalize specifically, but I know that the dominating substance use is alcohol on our men's and women's day treatment unit. And I'm not sure if that applies to those that can't afford to come to treatment or don't have access to insurance. But to touch on something that he was talking about just a few minutes ago, not only are they privileged, but internet access is so important to have for virtual services. And a lot of the marginalized communities don't have reliable or cost-effective internet access.
And too, we're seeing individuals who, they will cross state lines and call their provider out of their car because that provider may not be licensed in the state that they're living in. So if they're in Wisconsin, they might drive over to Minnesota. It's not straightforward or simple, right? I mean, and even that is a privileged perspective. I think that's, you can just tell me when to move forward.
Yeah, so what COVID-19, the pandemic has shown us is that the lockdowns, the job insecurity, the physical complications that result from either getting COVID or having to deal with children and family that have COVID, it increases chronic stress, economic difficulties, social isolation. And I'm assuming that most people in here had to subscribe to these restrictions, and it can increase depression and anxiety, which will show globally and in the United States. So the research is showing right now that relapse and worsening of mental health symptoms for vulnerable populations specifically has increased.
And just to add to that, we've never had a higher census than we did last year in Center City as a result of that. And that's just a subset of arguably privileged people, right? Because you have to have access to managed care or other resources to, drive out to Center City, let alone to access the services.
And not just for our facility. I know medication-assisted treatment centers have also seen a dramatic increase in patient population because it's easily accessible. But here, so the pandemic impact on mental health, you can see across the globe that everywhere is reporting increases in depression, sadness, grief, isolation, loneliness, anxiety. Particularly for the United States, 33% reported symptoms of depressive disorder. And this is information after the pandemic started. So that's an increase prior to 2020.
And just to add on to that, now we're starting to track cognitive deficits as well. I think that I have a list of at least 12 patients over the past month that meet the criteria for, Korsakoff syndrome or some other neurocognitive deficit, but because they've been using alcohol excessively for years, when we do the screening and the evaluation, whether it's face-to-face or not, it's hard to tell whether or not their limited cognitive functioning or decline is due to the substance or aging or other factors. And then we get them onto our campus, and they spend 2 to 3 days on medically monitored withdrawal management. They get transferred to the unit. They start getting lost. Peers start taking care of them. We administer different batteries, and on the slumps they're scoring a 16. Well, whether or not the slumps is predictive of any functioning or lack thereof, to fall within a normal range, you'd have to make up such a drastic difference that it's unreasonable. Even after a course of thiamine, which will often tell us whether there's something more going on, there's no change. They end up being on our unit, and we're in many ways caretaking for them. So now we're seeing that particularly impact the older population, where we had a gentleman in his early 70s who was a farmer, and he could farm like no other. He had that rote memory down, but he was also intoxicated the entire time. As soon as he detoxed, we could see and observe his cognitive decline, and then transferring to a specialized memory care unit as just another burden. And
to just add to what Damir just said, in the research, when I was putting together this presentation, it also showed an increase in the Wernicke-Korsakoff syndrome, and that's due to the increase in isolation and the increase in drinking during the pandemic.
Just and I'm not sure if you have this answer, but looking at that map, I don't know if you want to back up just one. I mean, some of the places clearly had much more restriction than other places. For instance, China, where they're still really limiting what they can do with outbreaks and stuff. Has that affected? I mean, is there a clear correlation between the amount of restrictions and the depression and anxiety?
From the research, it shows that the prolonged restrictions can increase and exacerbate pre-existing depression, but it didn't speculate on whether it increased it just solely based on the severity of the restrictions.
Okay, thanks.
Yeah, from what I understand, too, and Terry probably know better, but there isn't enough data to do moderation analyses and examine the directionality of these relationships. Although from what I've read, it doesn't look like that, or at least a very small percentage of people would have isolation-induced depression and anxiety. It's much more common to have it exacerbating and compounded by the pandemic and the restrictions.
Interesting.
Any thoughts on why Brazil is so much higher? Like the rest of them are kind of within that same area. Brazil, like 68%.
I don't have any concrete data to support why it's so much higher than everywhere else, but I would like to believe that their collection sample was larger.
The other thing that, at least in the US, one, the DSM is a Western construct. A lot of the disorders are Western, and we even see issues with translating instruments into different languages. So one of the common questions for depression is, over the past X number of days, have you felt blue? Well, if you translate that question into different Asian languages, blue is literally translated as the color and not the feeling that it infers. And so you lose validity and reliability in and of itself. So depending on how you're measuring and collecting the sample, your variability can be drastic. I think that's still you.
No, go back. So this one's for the United States here. Obviously, you can see on the table, 1 in 4 adults reported anxiety or depression during the coronavirus. And you can tell that those that had pre-existing conditions or comorbidities had a drastic increase compared to other populations. So the impact on substance use also demonstrated that people were using more substances more openly, but particularly for this slide, it talks about how those party-like drugs were decreased and the use of alcohol, marijuana, and benzodiazepines were increased because those are typically used in isolation and can be used in isolation. So cocaine, MDMA, ecstasy, LSD, mushrooms saw a decrease in use while the other ones saw an increase. And so substance use increased across the globe, and China showed that 19% of abstinent alcohol users relapsed, with 25% of abstinent smokers relapsing as well. And we see similar results here for alcohol use, and that's to be expected because, again, these lockdowns, the prolonged lockdowns, and those in marginalized populations are typically the first responders or they're the frontline workers. So they're introduced to more stress, and more stress leads to more substance use. So in the United States, this study determined that an increase of 13% of individuals use substances to deal with stress and emotions based on what they were going through. It didn't specify whether this was related to contracting COVID. This was just in general, but I would like to believe that whether they contracted COVID, they were a frontline worker, or they were just under the restrictions of their county and state, that it showed dramatic impacts on mental health. And more data to support that substance use, co-occurring disorders, we're not free from that, just like the rest of the world. We all saw an increase.
So the thing to add along those lines too is we're seeing an increase among healthcare professionals and other sectors. I mean, even with self-harm and suicide, you're not immune from the pandemic. It's pushed a lot of people to the edge and brink, and some of us, have gone from, being heroes and celebrated to then admonished for enforcing masking or isolation requirements. And that certainly takes a toll on people's identities and value belief systems. And, maybe some of us join this profession for different reasons, but I would like to believe that most, if not all, do so for the sake of wanting to help others. And when what we do gets challenged, it causes an internal conflict and dialogue. And at least over the past 2 years, there have never been more healthcare professionals in treatment, which on one hand is positive because we want them to get help. But on the other hand, we all know that, the consequences and implications of admitting a substance use problem, aside from the stigma, can have significant repercussions, right? On your license, your livelihood, and everything that you've invested thus far. And so how do you come to terms with that? It's very difficult. We often talk about evidence-based practices and interventions, and yet it seems to me at least that people think of different things despite referring to one. So evidence-based practice or intervention is based on scientific evidence to produce specific outcomes. For cognitive behavioral therapy, for example, has been shown effective in reducing ruminating or intrusive thoughts. Whereas evidence-based thinking, on the other hand, is a process through which different information is applied to clinical situations, meaning that you may have encountered a certain patient presentation or background, and therefore, based on your clinical judgment, knowledge, and training, you can logically deduce a course of action, treatment, or regimen. But evidence-based practices broadly are a combination of clinical experience, research evidence, and patient experience. So much of the recommendations, whether that be by SAMHSA or independent think tanks, don't include the patient experience. The threat of failing to do so is removing agency or an internal locus of control. Something that I'd like to emphasize over and over again is that individuals with an internal locus of control, those who believe that they have an impact over their life and their situation, are much more resilient to contextual factors and mental health or substance abuse disorders, whether that be depression, anxiety, or alcohol, than those who have an external locus of control. Because if you have the latter, you don't believe that you have agency. So what's the point of, therefore, engaging in treatment and participating and trying to make things better? And so without the patient experience, you take away, right, a very important component, even though as healers and as healthcare professionals, that's exactly what you're trained to do. Interestingly, now research is coming out showing that this plays a very important role in the legal profession, and that lawyers with an internal locus of control have significantly lower rates of depression and anxiety. So regardless of the interventions, there's a few guiding principles to think about. And this is important because yes, interventions are helpful. Cares of model are very valuable, but the strongest predictor of any successful treatment outcome is a therapeutic relationship, whether an individual feels heard, valued, and seen. Treated like a human being, especially with, I think, substance use, because so much of it remains stigmatized in our society. So leverage a recovery perspective, and that can mean different things to different people. To me, it means that no one is beyond redemption. We all make mistakes, we live and learn. But if we can do something positive with it, there's always hope. Adopt a multi-problem viewpoint, create a phased treatment approach, and address specific issues. I remember working with KU-FAM and several other people, some of whom may even be on this call. Vic Vines, was it last year, to get someone who was waiting on a transplant into treatment, and we managed to convince his insurance provider that virtual outpatient treatment from his house qualifies as substance use disorder treatment, and therefore he was bumped up the transplant list and flown to the Northeast for the surgery within 48 hours. Up until that point, his life expectancy was months, whereas the wait list was years. And one of the easiest things or most accessible is motivational interviewing. And again, I'm sure most, if not all of you have heard of that. And yet again, its meaning is elusive, but it's a counseling approach consisting of different approaches, ultimately aimed at eliciting behavioral change. So how can I get you to do something differently without fighting with you about it? And in many ways, helping you see for yourself that it's the best course of action. So it's collaborative. It relies on education, autonomy, and compassion. So instilling that internal locus of control. And it avoids confrontation, education, and authority. I'm going to go out on a limb and say that confrontation, well, at least that's something I do. Confrontation, education, and authority have historically been really inherent to the medical profession. Right, wrong. Maybe over the past 10 years, confrontation hasn't been, as we try to integrate behavioral health into primary care and other specialties, but education and authority certainly is. Right? Don't you know that it's bad to smoke? Don't you know that it's bad to shoot up heroin? Well, yeah, I kind of do, but that's the problem. I'm addicted. Right? And MI is therefore founded in expressing empathy, developing discrepancy, rolling with resistance, and supporting autonomy or self-efficacy. And so really reflecting an accurate understanding, think of a time when you spoke maybe with a friend, with a family member, and you felt understood without judgment. They just heard you. That's what we want to replicate. Human beings tend to seek patterns and render judgment because it's part of our, hardwired approach. But we really have to give people benefit of the doubt and assume that, they're trying to do their best, that their perspective is valuable, that they have something to add, and reinforcing and emphasizing throughout all of that without judgment. And then discrepancy is just contrasting their behavior currently with future goals, but doing so in a way that is empathic and supportive. So to give you an example, so a patient would say, I enjoy having some drinks with my friends. Drinking helps me relax and have fun. I think I deserve that for a change. So the provider would say, so drinking has done something good for you. Now tell me about the not so good things you've experienced because of the drinking. Well, I got fired. Or, rolling with resistance. Patient says, I don't plan on quitting drinking soon. A common response, which, I'm guilty of, is say, so you don't think that stopping is going to work for you right now. Think about it that way versus, it's a different example, but my husband is always nagging me about my drinking, always calling me an alcoholic. It really bugs me. It sounds like he really cares about you and is concerned, although he expresses it in a way that makes you angry. Now, this is not to take an extreme and justify inappropriate behaviors, right? Whether that be emotional abuse or verbal abuse, but it's taking a different perspective. And think of yourself, right? Or if you have kids, if you can make them think that it's their idea to begin with, you're going to get buy-in much quicker, right? And granted, I struggle with that. I just want you to understand it and not, I don't want to play games. But it's not so much a game as it is a path to understanding.
I want to just add here before you move on, it's important to evaluate the stage of change that the patient is in, particularly with co-occurring disorders, because, and if you're not familiar with the trans-theoretical model stages of change, it's how we evaluate where they are in terms of wanting to take action and make these changes for themselves versus family members or friends or professional affiliates wanting them to go get treatment. And so motivational interviewing pairs very well with the stage of change model because it helps transition them from pre-contemplation, contemplation, action, and then forward into a sober life.
And really, recovery is almost like a matrix model, meaning that you shift according to where the individual is. And as you're talking about the stages of change, I'm also thinking about how, our understanding of change has also shifted over the past few years, that it's not really linear, that you can go from acceptance to saying, hell no, I'm not doing this, within a matter of 2 days, depending on how you're thinking about it. And, at the end of the day, the vast majority of people who need help know that they need help. But when they feel that they're backed into a corner and forced to do something, if you really genuinely think about it and take an empathic perspective, they have so little autonomy and power to begin with over whatever substance they may be using. And now you're also pushing them and forcing them, albeit that it's in their best self-interest. But, that kind of takes away the hope. And I don't know about you, but I've seen and then talked to people where, there wasn't any hope in their eyes. And then when they find it for the first time, it's in some ways magical. And I don't mean that in a joking way, because none of us would be doing any of this if we didn't think that recovery was possible. You're an authority on medicine and your subspecialties, but the patient, the individual, the client, they're an expert on who they are. And I always say, look, I've known you for 20 minutes. I only know what you've said to me. I avoid generally looking at a chart before I meet someone, so I don't form biases and then go after those. But, finding that relationship, the balance, is what ultimately can help move people forward. And I think the field as a whole, through dialogue like this. And that's the presentation. I think we have some time for questions and answers too, or complaints.
No, I just love what you just said at the very end, that whole, you've known yourself your whole life, or, like I've known you 20 minutes thing. I use that a lot, I think, to get buy-in with patients. Like, I'm not coming home to your house today to take, force you to take these meds or do these things. Like, ultimately, that's your choice. I'm just going to kind of help tell you what I can, whatever. But
I always say I'm a tour guide. I'm.
Which is so funny, because if you've ever traveled with Kurt, that's like, you're going to get lost. So maybe you need to come up with a better
I'm just
analogy.
a tour guide. Yeah. I think
God.
just the one thing that you said, and how often, have patients said to you, well, they tell you the story, they tell you what everybody in their family's saying, and then they say, well, what do you think? Right? Where do you go with that?
Go ahead, and Terry, you can answer that and I'll follow up.
Putting me on the spot. So I always like to give patients agency and autonomy when they're with me, because they need that self-efficacy to continue to move them from stage to stage. And so I pass the ball back to them in a very sensitive, supportive manner.
Yeah, but then they say, well, do you think I have a problem? I mean, how many times has somebody said that to you? Well, do you think I have a problem? I mean, people say that all the time.
What's surprising, I don't have that a whole lot here, because at least most of the patients that I've encountered thus far, they're here willingly and voluntarily. However, I have had some training experiences where they weren't coming to treatment voluntarily. And I would say point blank, and we would review the criteria and what classifies them as having an issue. That way they can see tangible evidence that they do have a problem, whether they're ready to admit that to themselves or not.
So one of the best things you can do for yourself and your patients is develop distress tolerance. People want answers. I would go out on a limb and say that if I had a choice between getting a really bad answer right now or waiting for a good answer a week from now, most people would choose the bad answer right now. Because, okay, I checked the box, I'm going to move on. So holding on to that uncertainty is something that's really important to model. So when I'm with patients, I say that, and I emphasize and highlight and say, what difference does it make what I think? What could I possibly say that would make you walk out this door with a positive or negative idea of yourself. And then kind of shifting and reflecting on, and pushing back and saying, okay, you've known me for 20 minutes. Why does what I have to say weigh so much?
I like that.
And so it's rolling with the resistance. And then when I'm Minnesota passive aggressive, then I've sat 45 minutes in a group session without saying a word until everyone's really uncomfortable. And then we spent the last 15 minutes processing that. But it's about being comfortable in your body, in your space. And I think a lot of people, whether they're struggling with addiction of whatever kind, are afraid of being alone with their thoughts.
Yeah, I think that's huge. But I like that. What does it matter what I think?
Yeah.
Maybe you should go that instead of I'm the tour guide, because Lord knows we'd all be lost in Florida. You would have never made it back.
Yeah. It's like when I tell people, you can call me doctor all you want, but don't call me if you have a heart attack. Like deep breathing isn't going to be beneficial at all. So it's having that transparent dialogue and say, look, this is what I do. This is what I can help you with. You've obviously made it this far in your life. What is it that feels out of control? And having that genuine heart to heart human connection. I think that even those of us who are, categorically healthy, whatever that means, go through life by just spinning the wheels and the motions and connecting and being vulnerable. I don't know about you, but I'm not walking around campus, spilling my emotions to everyone.
Kurt does sometimes.
No, I do not.
Okay, so I have a lot of questions, but more or less anecdotal things. Like, what have you noticed or kind of what's changed in your world, especially with the COVID and with increases and all these things? First one, have you noticed that patients who are coming in maybe do have more of that awareness or more insight, or maybe you're getting patients who are being admitted, or you're getting in contact with who maybe 6 months ago would have never thought that they're alcoholic. They're becoming more introspective into, oh, maybe I am drinking more because they're at home or they're isolated. So.
And it's in the news. Everybody listens to the news and they know that the substance use is up and all the. And do you think that helps them recognize it?
Yeah.
Well, because I wasn't here at this location prior to the pandemic, I can't make an accurate assumption. But I'm finding that patients that I come across that end up in my chair are willing and ready, and they're here voluntarily. So they know that they have a problem. Oftentimes this isn't their first stint in treatment. So they realize that they have a problem. But I'm curious, Demir, since you've been here a lot longer, what's your experience?
I'm also contrasting it with working at the Department of Human Services, where people are civilly and criminally committed. I'm going to go out on a limb and say that even before the pandemic, most people know that whatever is going on isn't right. I'm just going to go out on the limb and say that. But doing the right thing is a function of partially privilege and environmental factors, social factors, individual factors. Maybe the pandemic has set some boundaries with people being forced to confront their demons quicker than they would have otherwise, because their spouse would have left them, or they did leave them, or their employers threatened to discharge them. And so that certainly plays into it. But I like to believe that and give people much more agency than we've assumed. I mean, our historical view of addiction and mental health is think about asylums, right? That people were relegated, they're lost causes, and don't worry about it. But they're still human beings. They have a sense of agency. They have a sense of self, and I don't think it matters so much that we can delineate what that means, as they are in pain, they are hurting, and if that's the case, they understand that it's bad.
Sure. At the very beginning, you talked about, your previous suicidality or all of that were previous exclusion criteria. And now it just can't be, because everyone's got, everyone used broadly has more of those thoughts. How did that change what you all had to do? Like increase staffing, increase like just changes in the structure, changes in treatment? Did that really shift it just because of this co-occurrence and everything worsening?
So, Tara, I'm curious about your perspective just day to day with patients, and then I can give an on-call and administrative perspective of what it looks like, of getting called at 4 a.m. by a charge nurse to call the hospital because the emergency room attending wants to send 2 frequent flyers back.
Well, administratively, obviously, I can't speak to, and Jameer will, but for day-to-day patient care, I think that an increase in support and staff obviously would be beneficial. We provide wraparound services here for our clients or our patients, and I feel like we could obviously use more support to provide patients and support them and protect them because we want to keep them safe. But I will defer to Jameer for the administrative.
But I think our threshold of risk, of acceptable risk, has shifted, meaning that what we would have maybe not admitted previously or accepted, we willingly accept. We also put people on observation on our medical unit much more so than we would have in the past. So that threshold has gone down. But we do so without regard or consideration for financial factors, meaning that when we do that, we write that charge off. When someone is in our medical unit, technically it's withdrawal management. It's billed at a couple $1,000s a day. Well, we're not doing that, right, in that capacity. And so we just write that off as long as we can make sure that they're safe. And then we reevaluate them. But then it's also, we were working with the Minnesota Hospital Association and colleagues across the Twin Cities to avoid passing the buck, if that makes sense. So let's say we involuntarily hospitalize someone for whatever reason, right? And I was on call one week, and at midnight, the charge nurse on the medical unit called me asking about what to do with the individual. And I said, well, take him to the MSU, the medical unit. And if you have any questions, call EMS and transfer him to the ED if it exacerbates into his behavioral de-escalation. And then I didn't get a call until 4 a.m. from the same charge nurse saying, well, we sent him to the hospital. And now the attending ED physician is calling back wanting to send him back. So I call the attending and we speak, and very kind. And he actually took a lot more time than I guarantee he had to talk with the patient and with the family. And we discussed that, he's the patient saying everything right. You and I can argue day and night and think that, they're going to go out right now and do something inappropriate. We can't prove it. Right. So we can't take away their civil liberties. And so we took the patient back. And it's funny, that same doc said, oh, by the way, you have another one here too. Can you get that? Can you get him as well? So we went and got both. And, it's about, and it's hard for us too, because I understand that if I send them to the hospital, 1, I probably won't get a bed. 2, they're one of how many waiting to get services. And, unbeknownst to the general population, there isn't a magic wand that the emergency department has that can cure or fix all. It's almost like getting a second opinion. And part of that, I was at a conference this week and I spoke with legislators about how the mental health system is in this country is fractured, period. We've gone from deinstitutionalization with John F. Kennedy to, some states implementing community behavioral health services, but really the rest of it falling to the private and public sector to pick up. And it's the issues Minnesota has are not unique to Minnesota. Every single state has them. And so again, our threshold has gone up, and we view as self-harm as, attempts of coping with something that's very challenging and difficult, and try to instill hope and manage and control reactivity from an administrative standpoint and empower the staff so it doesn't feel like that there's spillover effect, right? Because if the staff feel out of control, then the patients will feel out of control.
Right. I don't know. When you said the whole 4 hours later, they called me back wanting them back. I'm one of the people whose video is on is a nurse in a jail. That was funny because having worked in jail for a year, 4 hours was really nice. Usually it's like an hour if you send an acute patient from a jail and they send them right back. So no, it's just with your reaction, Audrey. I'm sorry, I had to point out. But have you noticed with, I'm thinking more your medical provider kind of clientele that you have, any differences in that in patterns in terms of people having more of that internal locus of control, depending on what kind of generation they fall in and how amenable to whether it's co-occurring or just, substance use disorders and treatment success, if you want to call it that. Have you noticed that? Just because you did mention, the old school doctoring was much more authoritative versus younger, different education patterns.
Yeah, so I think that definitely, I'm going to talk about patients and then providers, but with providers, we're definitely seeing a lot more flexibility and rolling with the punches and just doing the best that we can. For example, to cover some of the psychiatric issues with anxiety and depression, we have our formerly primary care providers or emergency docs on our medical unit prescribe anti-anxieties, which, they might as well take Benadryl. But it's almost like a placebo effect, right? It's about the relationship and being there with the person. So there's a lot more collaboration. Of course, it varies by provider. And then we have also different providers, depending on their specialties, who feel more comfortable prescribing stimulants to treat neurocognitive disorder like ADHD, for example, concurrently with substance use disorder, where there's a very fine line that you can cross into over medicating or abusing. So there's a lot more interaction, collaboration, flexibility, freedom, understanding. And we're seeing this kind of a similar trend on the other side. Patients who are providers. We're seeing many more providers who just got out of their residency and training programs who end up at our front door. So that's one extreme. And then another extreme is seasoned executives, physician leaders. I mean, you're either at the beginning of your career and imagine, right? You starting your career in the middle of the pandemic or beginning of the pandemic, to physician leaders who are, towards the end of their career, but feel like that they have to stay strong for everybody. And at the end of the day, they're just a human being.
Interesting.
Yeah.
And Tara did work at a jail, so I was just thinking about that.
Not a jail, it was a prison, but very different.
Tomato, depending on who you ask. I know, I'm kidding.
Yeah. We've also seen an increase in eating disorder
Right.
patients as well. And I think that's important to note here because typically, historically, Hazelden hasn't accepted active eating disorder patients. They need a higher level of care, but because everyone is stretched so thin and access to eating disorder treatment is limited at this point, we've been taking them in, so they get a lot more supervision from us as well.
Yeah, that's a good point. I was just talking with someone else too, that, there's always a conversation, a higher level of care, right? Higher level of care. That's me assuming that my friend Alex Hubble has more resources than I do, right? Exactly. And, I think that we all believe that the other one does, but we're all kind of stretched thin. So we're really trying to manage expectations and do the best that we can to do our part, because at the end of the day, who suffers? It's the patient, because they're getting shuffled around.
Yeah.
I think sometimes that term higher level of care as well is, as a provider, sometimes you're just like, I don't know what to do, and the patient's getting frustrated and you're getting frustrated, and staying high level of care has the patient kind of have the buy-in that you as the provider understand that there must be something, or that they have, they at least know that you're trying. With the flip side is, if there is no more research or resources with Alex or Carly, that that could
honestly think about how much, stay curious of how much of that is countertransference. If you feel so hopeless about all of this and you get to go home at 5 o'clock, think about what it's like for this individual who doesn't get this is their life, they're home, and the hopelessness that they experience. And take it one step further and think about what it would feel like to feel abandoned. with that. Sometimes just being there and listening and validating and saying, you know what, I don't know, but we'll figure out together, can be just as powerful.
All right.
All right, any final thoughts, questions? I don't know, Tara, if you want to add anything, I think for a student, if that's, I mean, really what you are, because it doesn't sound like it, but it's great that I'm glad that you were able to join in this presentation. But if anybody has any other questions or final thoughts, go for it.
All right. None being heard.
Kurt doesn't like to sit with his thoughts in silence
No.
ever.
No, for like a second. No, well, we thank you so much, Tamir, for coming on. And Tara, that was fabulous. And I think kind of something for us all to think about as we go through our days, how we approach these situations. So thank
And
you.
reach out if you need anything.
We will. Your higher level of care.
Yeah, that's right.
All right, everybody. Next week, Kurt will be talking about substance use in older adults, which
Yeah, opioid use in older adults. So have a good week, everyone. We'll see you then.